Welcome, my name is Arthur Rosenbaum. I've been in practice in New York for 35 years. I am a board-certified foot surgeon. When I graduated many years ago, I was introduced to a new methodology of performing foot surgery. This group is known as the Academy of Ambulatory Foot and Ankle Surgery, an organization totally dedicated to deliver optimum foot care through the use of minimal incision surgery, which is the use of small incisions, a concept which corrects foot problems and allows for quicker healing. Today, there are other medical specialty branches that also perform the same type of services. For example, in the field of cardiology, years ago, the entire breastbone had to be broken and spread apart to get to a heart. Today, with the use of a small incision, a probe can be entered into the human heart cavity and the problem be corrected. The point again is a smaller incision, less inflammation, less trauma, quicker healing. Today, I will attempt to cover the most common foot problem, a long-standing debilitating problem in the healthy adult. It is called the painful bunion. First, a thorough history of the patient will reveal the cause, the diagnosis, the course of treatment, and the cure. Also taken into account is the duration of how long the condition has been present, the severity, whether it be mild, moderate, or severe, a family history, which will contribute to hereditary factors, and the wearing of poor or ill-fitting shoes. A physical examination will include an examination of the entire lower extremity as well as the foot with respect to its bones, the vascular system, which includes pulses, neurologic system, which includes the nerves going into the foot, and musculoskeletal system, which includes the tendons, ligaments, and muscles, especially those influencing the first metatarsal phalangeal joint or bunion joint. X-rays of the foot will be needed. A biomechanical examination with gait analysis will also be provided. The goal of treatment is to reduce symptoms and allow the patient to maintain and return to normal activities. Although it is recognized that a certain percentage of patients will not receive complete relief, it is expected that a vast majority will gain significant improvement. Non-treatment of the problem may lead to additional pain, progression of deformity, possible infection, possible ulceration, bursitis, tendinitis, and extreme degenerative joint disease. Now that I have presented an overview, I would like to get more specific. The foot works as a tripod. It's supposed to come down at the heel and land on the first and fifth metatarsal and then toe off. Most patients who develop bunions have a problem with this, in that when they come down, the foot does not come down at exactly in the middle of the heel. Then as you start to walk, the foot then pronates, where all the joints in the foot become loose, allowing the foot to move over. Then it supinates or turns back on the outer side of the foot and then toe off. What happens when you develop a bunion is simply an inability for all the parts to work at the same time in tandem. If I were to line up her foot exactly where she should come down, it would sit over here, and you would notice a big gap in the foot. This is the arch area. Some patients present themselves with a very high arch. Other patients present themselves with a very low arch. This creates a problem in that it creates additional stress on the metatarsal. Normally, when we're born, all the bones should be completely aligned, with the joints, as in your fingers, completely straight. What happens when you have this non-alignment is you start to develop the bunion deformity. This bone is allowed to twist outwards, which causes the big toe to turn inwards. That creates what is commonly known as a dislocation. When it becomes extremely severe, it becomes known as a subluxation. The reason why patients get pain is because the joint is not in alignment, it is not congruous, but slightly dislocated. Let's put it into normal terms. If you were to stand next to a door, which is off its hinge, it would creak and bend because it's not in alignment. If you were driving in a car and one of the wheels was slightly lower, eventually the car would be out of a wheel alignment and you would be shimmying and rocking. Let's move to the body and use the teeth as an example. If a tooth comes in crooked in the back of the mouth, it will push all the teeth in a crooked direction. The foot works the same way. If the foot were allowed to come down perfectly centered in the heel and land exactly where it's supposed to be, there would be no problem. However, most people do develop a low arch or a high arch, which forces the foot to do this extra motion and create the bunion joint, which again allows the big toe to push inwards, and with time will eventually push the second toe out of the way and develop hammer toes along with the other toes. Some patients, after a while, will develop on the bottom of the foot a callus underneath the second knuckle. The reason why this happens is because the first joint is out of alignment. So the body obviously goes to the next bone and it picks up all the pressure, creating a callus. With time, if that's not treated, the callus then moves to the third bone, possibly to the fourth bone, and very often the fifth bone. This creates what we are known as a hypermobile foot. Again, when she walks, her foot is going in this direction, when in fact it should be going straight up and down. This can be corrected with two things. Number one, surgical, to get the foot realigned perfectly straight, and then with the use of an orthotic, which is an insert that goes inside the shoe to maintain the correction. The orthotic takes the space and creates a normal arch and allows the foot to walk straight up and down instead of at the rocking position. This will conclude our biomechanical portion of the foot. Now that I've explained to you the cause of the bunion, I would like to explain to you about the course of treatment. It is my valued opinion that all the conservative treatment for a moderate bunion will eventually fail, depending on whether you have physical therapy, which is short range, injection therapy, with injecting corticosteroids into the joint, again will give you short range, modifying shoes, which is extremely difficult because they have to be extremely wide and bulky and cumbersome, which most of the public will not accept. As far as family history, hereditary often plays a very vital role in bunion deformity. I find today that patients coming in are of a much younger age as opposed to years ago, accepting the fact that they do have a problem and wanting to correct it, rather than just shoveling it in another shoe and delaying the process and developing additional foot problems and foot pain. Shoes are not a big deal as they were years ago. Many patients can find sneakers that are comfortable, and the shoes today are also more comfortable and will accommodate some mild bunion deformities. With respect to bones, the foot presents itself as either a mild, moderate, or severe bunion. The mild bunion is called a positional bunion. That is often the case where all the bones are technically still lined up properly, as you saw in this diagram. However, through the use of ill-fitting shoes, the straps or where the shoe bends will create an excessive amount of bone or a calcium deposit on the outside of the bone and create a bunion joint. We also find this in patients that develop problems due to sports. With the gentlemen, I very often get what's called soccer foot. They play soccer, and by kicking the ball excessively, they develop a spur around the joint, and that creates pain. The third possible way that you have that creates this is due to sports or running injuries. Patients who are constantly running or excessive walking and not changing their shoe gear often enough will develop problems whereby the crease of the shoe will dig into the bone and eventually create the calcium spur. This bunion is very easily corrected because all that's involved is the extra spur be removed. The most severe type of bunion deformity, which I just want to touch on, is where the bone is completely out on an angle. This can be done through several ways, including hereditary factors, where both parents have severe bunions. But more than that, it is usually done with inflammatory conditions, such as rheumatoid arthritis and gout. There's another condition that causes this, and that is a failure in uterus, embryologically, for the foot to completely derotate, which will also leave the bone at a slight angle. This is a little more involved and may sometimes need an osteotomy or a cut further down at the base to move the angle more straight. We're going to leave this for another discussion. The discussion that I would like to center on today is the most common foot problem, as you saw on my model, and that is the moderate bunion. The moderate bunion, again to review quickly, is created by the bone being able to rotate outwards in excess of what is a normal position. This is also a structural bunion. Very often, these sesamoid bones, which are these two small bones found underneath the large bone, which we need for locomotion, for movement, will be displaced. And that also will lead to an additional turning out of the bone. Again, this procedure can only be corrected if the angulation of the bone is moved in. This is created by the osteotomy procedure. And usually all it means is filing down the bunion, making a surgical break in the metatarsal, and very often if there's a very large deviation of the large toe, a wedge would also have to be removed there in order to give the toe a total alignment. Once we get these joints completely lined up, the patient will be pain-free. I have prepared several surgical corrections of the moderate bunion so that you can understand what I'm trying to accomplish. This is a 25-year-old female who presented to the office with extreme pain in her bunion joints after having tried all forms of conservative therapy, which I discussed, including injections, physical therapy, strappings, and non-steroidal anti-inflammatory medication to no avail. No matter what type of shoe she wears, she always has the redness here and has a limitation of motion around the bone. X-rays taken of the foot, the right foot, I'll discuss that first, show that the bone is sticking out, just as I explained before with the live model. As you can see, all the joints are perfectly in straight alignment. However, this joint is slightly what we call dislocated, or off the joint. As a result, every time she walks, the joint is not aligned, it is off the joint, creating pain and discomfort. The objective is to get this first metatarsal into complete alignment, again from a position of this to a position of this. As you can see, post-operatively, after the surgery, this is two views of the same foot. You can see where the bone was broken over here and in the large toe, and now the foot is in complete alignment. The same goes with the left foot. Completely out of alignment. After the surgery, complete alignment. 6 weeks post-operatively. That's the right foot before and after. The left foot before and after. A second similar patient, 10 years older than the other patient, again presents with the same problems. Inability to wear any sort of shoe without being in great discomfort. Her problem has even developed further, where now the toes are starting to curl and become flexible hammer toes. A picture of the right foot. The x-ray shows a complete dislocation of almost 65%, whereby the bone is sticking out. The other bones are in complete alignment. This toe is dislocated. And every time she moves, she's in constant pain. Post-operatively, there's a fracture. We remodeled the bump. We created the osteotomy fracture. And we straightened the large toe. And as you can see, we have a perfect joint here as all the others. Left foot before, left foot after. Right foot before, right foot after. Note, there are no scars, no lines, no swelling. This is 6.5 weeks post-operatively. Case number 3 is a gentleman. He's in his mid-40s. Again, inability to walk. As you can see, his is even more progressive, but still in the moderate phase, not severe. Redness around the bunion joint, inability to wear any type of shoe, except for a sneaker, and even then in great discomfort. The large toe completely starting to push over and crowding the lesser toes. X-ray reveals even more dislocation. Post-op X-ray shows a straight alignment. And as you can see, before and now after, foot is completely straight. His right foot as well, before and after. I've just discussed with you the duration, the cause, the course of treatment, and the surgical procedure. And for those that do not want to see the following demonstration live, I will briefly discuss it using this model. The patient comes into the office on his or her own free will. After everything has been discussed, they will sign a consent form to have the procedure performed. It is done under local sedation, which is local anesthesia, and some patients will even opt for anesthesia, which I call amnesia. That's intravenous, light sleep, anesthesia so that they don't hear what's going on in the operating room. The area is numbed up through the course of three small incisions. A small incision made removes the bunion, a second incision creates the fracture, and the third incision, if necessary, creates a fracture to straighten the large toe. The patient then leaves the office with written as well as post-operative instructions, including the icing down of the foot and some analgesics to take for approximately 1 or 2 days. She or he will return to the office on a weekly basis to have the bandages changed until the fracture is completely healed between 6 and 7 weeks. Most of my patients do not experience any pain. I wish to emphasize that once the surgery is corrected, the patient will then have to be followed up with a pair of orthotics in order to maintain the surgical correction and prevent additional deformity from setting into the foot. Now let's go over this one more time because this is extremely important. The moderate bunion, once it is corrected in the straightened position, will still want to walk in an inefficient manner. The orthotic will then make sure that the foot walks in its proper manner. In combination with the surgery, will give the patient a great amount of relief. The advantage to minimal invasive surgery is the fact that we can deliver a procedure that's performed in the office versus a hospital setting, which a patient is extremely more comfortable with and walks out on their own power. There are no pins or screws inserted into the foot. That works well sometimes. At other times, it may create arthritic problems for some patients. There are no canes, no walkers, no wheelchairs, no crutches. The patient is requested to apply ice to the foot 20 minutes out of every hour for the course of a day or a day and a half. Analgesic medication is given, not always taken, depending on the patient and depending on the severity of the surgical procedure. Patients return in a week for suture removal and bandage changes, and the bandage changes are performed on a weekly basis until the fracture is completely healed. Once the patient has a healed surgical procedure and is wearing their biomechanical orthotics, they will get great relief.
Hello, my name is Diane O'Connor Camp, and I am a patient of Dr. Rosenbaum. I'm here to let you know that I had surgery done on my right foot a week ago, and I was so pleased with the way that I felt, the experience that I had. I haven't had any complications. The surgery went very smooth. I woke up fine and alert, and I was so pleased with that I'm back to have the second foot done today. I wish I hadn't waited so long is the only thing that I can say to you.
We are applying a betadine scrub, which is a surgical preparatory scrub, in order to make sure that the areas totally cleansed and ready for surgery. The foot has already been anesthetized. This is a moderate type of bunion deformity. The procedure that I'm going to do is called a step-down osteotomy, which includes several parts. One, remodeling of the bump that creates the bunion, then surgical breaking of the bone, which creates the osteotomy to move the bone in, and then an osteotomy on the large toe to straighten it out. And an incision is made next to the bump. It is deepened all the way down to bone with another special minimal incision surgical instrument. The capsule which lines the joint is separated from the bone. The advantage of this procedure over the standard traditional surgical procedure, which includes a long incision from down here all the way up here, and then requires all the layers to be opened, this procedure allows the surgeon to go immediately to the bony area without disrupting all the circulatory apparatus, nervous apparatus, and musculature on this side of the foot, which in turn reduces swelling. This part, which remodels the bump, can be done either with power equipment or with manual equipment. In my professional hands, I've been getting better results with the manual because there's less tearing of capsular tissue. You will notice a white pasty material that comes out of the skin. That is the bump that the patients call the bunion. This will go on for a couple of minutes until the bony protrusion is completely eliminated. As you notice, as more filing is performed, the bump gets reduced more and more. This is all what we call bone paste. The bump is completely gone. As you can see by pressing in on the skin, it goes all the way down and it is flat. The reason why we do the osteotomy is simply because, as I will explain later, is because the angle of the first metatarsal is an outward position. And therefore, if you just file down the bump and that bone remains in an outward position, the bunion will reoccur and will be a failure. We have the use of a fluoroscope machine, which will show me whether enough bone has been removed. As you can see on the fluoroscope, the excessive amount of bone that was sticking out over here. The x-ray showed a tremendous amount of bump. That has been eliminated. Second part of the procedure, which involves cutting the bone, is marked with an instrument that shows me the exact location of the surgical neck and find the exact area where I need to drill my hole in the bone. There are 3 cuts that are performed in order to get the bone in correct alignment. Through a small incision on the large toe, we will now take out a wedge of bone, just enough so that the toe will move from a position of leaning in to be perfectly straight. I add additional Marcaine, which is a long-standing anesthetic. Boris, one more stitch. The foot is now washed with peroxide. And as you can see, the bunion has been removed. The bones are completely in alignment. We will show that to you in an x-ray that will be taken in 2 minutes. Gentian violet is used to dry up the surgical areas. As you can see, even a week later, it's still on the other foot. A betadine-soaked piece of adaptic is used in order to separate the gauze from the skin, so when the bandages are removed, there's no necessity for tearing the skin. Remove the stitches from the foot that we had performed last week, and I'm repackaging the foot, which includes bulk bandage of cling gauze and tape. The beautiful part about minimal invasive surgery is that no pins or screws are utilized. I've been doing this for over 25 years. The bones will be held together with tape, which I'm putting on the foot right now, and a soft cast. These bandages are changed on a weekly basis. The patient gets a whirlpool in order to reduce the swelling and to clean up the foot. It is again repackaged with the same amount of taping until the bones are healed. And as everybody knows, a fracture takes approximately 6 weeks to heal, whether you put a screw or pin in there or not. It takes 6 weeks for enough new bone cells to be born and to lay down a new network to heal a fracture. That part was our taping. We are now applying applying the soft cast. This will go on the surgical foot as soon as x-rays are taken, and then the patient will be discharged. Soft cast, which is impregnated with zinc oxide, which also aids as a healing. We then use Coflex, which protects the patient from herself, so that if she bumps her foot or something falls on it, she cannot disrupt the healing process. Is press on the tip of the toe, see the color return instantaneous, so I know that the bandage is not excessively tight. The toes are in alignment, and the final elastoplast covering is placed on the foot. We're going to review in short what happened during the surgery. If this was the left foot, the x-ray that corresponds to the foot that we performed had a bone that was slightly enlarged and sticking out. As a result, the bunion alone, if it was just removed and the bone is out on an angle, the bunion will return. That encourages us to make a cut in the bone to realign the bone so it should look like all other bones with the joints congruous, which means in alignment. If I were to draw a line through the center of this bone, you would see that the knuckle is about 40% or 50% off the joint. That is the reason why the patient is having pain and discomfort. So to review, the first procedure that was performed was through the small incision, whereby I filed down the bump. As you can see, the bump is completely gone. The next part, with the use of the fluoroscope machine, was to mark the surgical neck, where the three-plane cut would then be performed to move the bone in. As you can see, the cut was performed and the bone moves in. The last part of the surgery meant straightening out the large toe, which was bending inwards, to making that straight. In order to do that, we had to take a wedge of bone out of the proximal part or the early part of the large toe. That again was marked with an instrument. I then went in and straightened it out. I will now show you a post-operative x-ray, which will show you that the joint is complete alignment. Okay, this is the surgery that we just performed. As you notice, this was the preoperative x-ray with the bone sticking out and the large toe turning in. And as you can see, I removed the bump, which is the actual bunion joint, but because the bone is out on an angle, it needs to be realigned. Now notice, every joint here is congruous or straight. That means she can't have pain. Once this is off the joint, you're going to get some form of pain. Now that it's realigned with the large toe, there's a fracture here and a fracture here, but the bone is completely straight. This will fill in and that will fill in, and the patient will wind up with a straight foot. She'll be able to bend the joint pain-free. And that's what we accomplished with this procedure. It will take approximately 6.5 to 7 weeks for this to knit and for it to be completely strong so that she can go on with her normal activities. I don't anticipate any swelling. I don't anticipate any infection or delays. And the patient should have a very good result. I strongly advise anyone with a bunion deformity to seek a qualified surgeon and even a second opinion. The important part is early detection and correction. Thank you.